Welcome to another one of my videos. My name is D. Campbell, I'm a coding educator. In today's video we're going to be talking about pre-op guidelines and making certain you're not getting denials and that you're reporting them properly. Here is a quick little screenshot of all the different information that we're just slowly going to work down left to the bottom here. The guidelines for coding here is actually quite clear where we actually have a guideline specifically for pre-ops. I have it below here where it breaks it down. We must sequence as followed here. Z01.81 must always be the first listed code. This is a pre-op examination code. Makes sense, it indicates to all payers and insurance and whatever that is what's happening in this visit. We are having a pre-op. After that, you must assign a code for the condition to describe the reason for the surgery. Make certain you don't just simply say patient's having total knee replacement. Make certain to indicate why they're having the knee replacement, so that way the highest level code can be assigned. And finally, code also any other additional findings related to it. When we're coding it, here will be the sequencing order for ICD-10. You will always first list the Z01.81, the pre-op code. Secondly, you will list the ICD-10 code for what is being addressed. Make sure to document to the highest level of detail possible, so that way the highest code can be assigned. At the end, I'll go through a little bit more information on it. Assign all chronic and or acute conditions that were addressed during that visit, and finally any applicable screening codes or Z79 for long-term medicine codes that are related to this visit. That's how we will sequence these. For CPT billing, how we will bill these visits is we will bill them as an office visit code, an E&M code, using time or medical decision making, whatever is greater. I do see a lot of providers tend to bill these as physicals or preventative service visits. I understand the thinking because it's a pre-op visit and you're kind of more hands-on, that you would think that that's how you would bill it. However, you do want to bill it as an E&M code for two reasons. One, you have a high likelihood of having a denial since you're not reporting it with a ZOO code. And second is if it does get accepted as a preventative service code, most payers only allow each patient one physical visit per year, so you don't necessarily want to waste it per se on the pre-op visit. Instead, you want that physical code to be usable when it is more appropriate. And then you will also bill all labs that are ordered for it. So when you bill, you can bill on time or medical decision making, whatever's greater. Here's the timetables here. If you use additional time, please report a 99417 or a G2212. We'll go on more detail on medical decision making on one of my future presentations. Otherwise, I do have a current one on medical decision making that please review. Just make certain when you're billing on time, you only bill for this kind of information and during the period of the actual service itself. How risk is categorized, though, for medical decision making. We're just going to do a light review of risk here, just specifically the surgery side of things. How risk is defined is risk is the assessment of the level of risk affected by the nature of events under consideration. It's the risk of treatment and the probability of consequences of an event. That's what risk is. It's the risk of care. We can break down risk in kind of two separate groupings, where trained clinicians can apply common language using meaning terms such as high, medium, low, or minimal risk, and you do not require quantifications for these definitions, though quantifications may be provided when evidence-based medicine has been established. Probabilities. So basically, as a provider, use risks explicitly. Say, I think the risk is high, I think the risk is medium, I think the risk is low. If you can, add some information for it, but you don't necessarily have to. However, if that information's not there, then us coders must use the examples only for it. Now, this is kind of a gray area here where I will explain kind of my opinion on how risk is counted and how most auditors and deniers are going to count risk. Risk also includes medical decision-making related to the need to initiate or forego further treatment and or testing. I personally believe with the further treatment that we can't necessarily count the risk of the surgery in that visit. If we look at the notes here, every single time it's decision of, decision of, decision of. The decision for the surgery has already been made in the initial visit where the provider decided the best way to treat this is with the surgery. Now the patient is purely just doing a pre-op. So to count that risk again is kind of double billing, and that's how a lot of auditors will feel about it. However, if you choose to forego the treatment due to what happens during the pre-op, absolutely you can then count the risk of that surgery. Otherwise, you're going to use the risk table and medical decision-making table as followed. We're not going to go into huge depths on this. Please watch my medical decision-making video if you want to learn more about it. But still, even if you don't count surgeries, generally speaking, we'll still be in the 4 because there's usually going to be some medicine addressed. And generally speaking, we're going to have 3 labs ordered. So we'll have these 2 categories as a 4, thus our visit is still a level 4. So I meet a lot of providers who will bill every pre-op visit as a level 5 just because of the fact that a surgery is happening, but really surgery is broken down into 3 different groups of categories, or you will always bill it as a preventative service. Just make certain you're billing it properly. Usually to me as a coder who reviews multiple pre-op visits, I usually see them in this level 4 window, occasionally a level 3 if it's more a minor surgery going on. But generally speaking, it's very rare that I will see a level 5 pre-op visit unless it's being billed on time. So finally, here's a risk table that I have for it for another way to count it. But once again, I will just point out that it's discussion of surgery and decision of the surgery. So personally, I won't count it myself when I am auditing the note, and most people who will deny it will not count it. But that's it. That's how you do pre-op visits. But remember, you can credit the prescription drug management, even if it's just simply prescribing, renewing, changing, or stopping. You can then count that medicine. So if you have to make a patient stop one of their medicines before a surgery, we will still get to risk 4 pretty often. And my name's D. Campbell. Thanks for watching another one of my videos. This is pre-op visit. Oh wait, nope, I got one more real important one to end on here. And finally, my key takeaways on this subject is clear documentation whenever we're addressing pre-op surgeries. The reason why I want to break this down is coding guidelines have us have to code to the highest level possible each and every time. For example, here's some major surgeries that we'll see very often. Cataracts has 111 codes. Fractures were at 3,900 codes. Hernias were at 60, and arthritis were at 600 different codes. So as a provider, make certain you're documenting it to the highest level of detail possible what is happening to this patient and what is being addressed, so the highest level code can be reported, and thus we can make certain we all get paid for it. Fractures, for example, are so large because every bone is broken down, and it's usually broken down by distal, proximal, then it's broken down by fracture type, and then once again it's broken down by healing status. So just make certain you give your coders as much information as possible, or you yourself as the provider assign the highest level code you possibly can, so that way you can make certain these pre-op visits are getting paid. And now, once again, my name's D. Campbell, and thanks for watching my video. Have a great day.